And welcome back to psychopathology, focusing on phobias at the minute. So we've started looking at an introduction to what makes a phobia, the behavioural and cognitive and emotional response. Hopefully you can pick out in a scenario each of those. We then last time looked at an explanation for phobias, so a behavioural perspective, looking at the two-process model from Maurer in 1960. So how classical and operant conditioning and social learning theory work together to give us a bit more of an insight as to why people develop or how people develop phobias. So now we need to look at treatment. So this is how it's going to work for OCD and depression, our last two bits. It's relatively short section, psychopathology. But it is one that students struggle with quite a bit because it's very easy to mix up the three conditions. So it's making sure that you have enough practice on knowing the specifics of each. So we're looking at treatments today, a behavioural treatment for phobias. And then next time we'll move on to looking at depression. So quick recap quiz. If you wanted to test some of your previous knowledge from previous topics, which I always recommend you doing in your free time, once you've finished your subject notes, spending, well, ideally 4 hours a week per subject on independent time, or just whatever you can, going over previous knowledge, so you're always embedding it as you go. Because like I said, we've had nothing from the exam boards to say that they're going to cut modules out or they're going to shorten papers. So at the minute, we're going with everything that you need to know from the course you're going to be tested on. So try and keep yourself in a good habits and good routines. So the recap, when it first emerged, humanistic psychology came to be known as what? The first force, the second force, the third force, or may the force be with you. What is not a way of sampling behaviour in an observation? Authoritarian personality is measured using what? Peterson investigated what in memory? And then the strange situation can be described as what kind of study? So take a minute, pause this, and then I'll pop up the answers so you can test yourself. So we have the third force, stratified, systematic, volunteer, random, and opportunity. All of those you do not use in an observation. When you're doing sampling in observation, it's time and event. The F scale, the fascism scale, was to look at authoritarian personality. Peterson, we did it in class, looked at the duration of short-term memory, and it sort of gets worse after about 18 seconds. And then Ainsworth, strange situation, was a controlled observation. Two-way mirror, looking at mothers and infants. So whatever you didn't know, maybe guide that as somewhere that you can tailor some revision maybe. So just recap to yourself, what was the two-process theory of explaining phobias? How did these two individuals and their theories come into play? And the answer to that is they are acquired through classical conditioning. So you learn, you by association, and then you maintain it, so it maintains over time using operant conditioning, mainly negative reinforcement. So you're avoiding that situation, which means that it's continuing. So treatment of phobias today. There are two that we have to know inside out. And I had some really great videos I'm going to get you to Google just to really put it into perspective. We've got systematic desensitization and flooding as our two ways of trying to help people deal and treat the phobia. We need to look at research, justify if it's effective and appropriate, and then evaluate both therapies. What are the differences between the two? Is there any that are better than, is one better than the other? So starting with systematic desensitization. Now, on the whole, this has become the main treatment for phobias. So if you go to the doctor and say, I have a real tendency, I'm struggling to leave the house, or I'm really struggling with a social phobia or whatever, this will be what they refer you to. So systematic desensitization. And It's based on classical conditioning, which is a pro for the two-process model because treatments have been developed based on classical conditioning, which is how they argue it's acquired. So they gradually learn to replace fear responses with feelings of calm. So the idea is that you can't have anxiety and relaxation coexisting at the same time. It's one or the other. So what happens is they reach a peak of anxiety. They get to the highest point that they can possibly go, and then they pivot back down. So it's a bit like a peak. They peak at the top, really, really anxious, and then over time, gradually, that decreases to feelings of calm. So they then learn this new response called counter conditioning. So we spoke about this a little bit last time. So it's replacing those feelings of fear with feelings of calm because they can't exist at the same time. When you've got one emotion preventing another, so fear preventing calm, it's called reciprocal inhibition. So that's a key word for you, reciprocal inhibition. And then lastly here, the key thing with systematic desensitization, it's a long word, I'm just going to call it SD, is a gradual process. So it's step by step. So we'll have a look on the next slide, but you have this like anxiety hierarchy. So what you can cope with, taking it step by step, all the way to the top, being in contact with the phobia. Okay, it takes about a month. It's gradual. It takes a little bit of time to learn and practice, but it has been deemed to be the best or the main treatment. So it's usually how they do it is through imagining scenarios. So I actually did this with one of my students a couple of years ago when I worked at Matravers. And she had a real social phobia. She wasn't very good in social situations, and she never really spoke to people. So I thought, right, we'll try a little bit of this. Obviously not as specific as what a therapist would do. But I told her to imagine scenarios where she is talking to strangers. And she came up with things like going to Tesco and talking to the person behind the counter. And this is called covert desensitization. But sometimes, over time, it can evolve into vivo desensitization, where you're actually in physical contact with the scenario you've imagined. So, for instance, this girl, she imagined speaking to the cashier at Tesco, so covert desensitization. As she built up and worked up the hierarchy and built up her confidence, she then went into Tesco, and the imagined scenario that she had, she actually spoke in person to that individual. So going from covert to in vivo. So it's 3 processes: an anxiety hierarchy, relaxation, and exposure. Okay, so this I've got a video there. I haven't got the link actually on there, so type it in and have a watch. I can't remember what this one is. I think it's a lady with feathers. No, that is one I want you to look at though for flooding. Yeah, I can't remember what that one is. I'm sure it's good, whatever it is. So the anxiety hierarchy, so here, together with the therapist and the individual, they build up an anxiety hierarchy. So a degree of fear from 5 to 100. So they start to list things. So let's say it's a phobia of spiders, looking at a spider, a picture of a spider, and then holding a spider, something like that. So the therapist will, once they've got their hierarchy, they then train the client in deep muscle relaxation. So things to really put a bit like meditation, as calm as possible when faced with the stressor. They then work through the hierarchy together, so maybe showing them a picture, eventually, bringing them into contact with a spider, talking about the anxiety, rating it on a scale whilst practicing those techniques. And then in some cases, depending on what the phobia is, they will confront their fear. So in vivo, they will then, presented with a real spider, hold it in their hand, and a bit like I said earlier, anxiety peaks and then declines. So if you're ever really, really fearful of something, remember that you can only reach a level and then it will sink back down. So have a look at that. Google also into YouTube. There's a lady who's got a phobia of, maybe it's on flooding. Have I put that on there? Potentially. A lady with a phobia of small spaces, and literally she shoves her in a room in a small space, and the woman's anxiety gets to that full-on peak, and then she's fine. So this is flooding. So it's called implosion therapy because you are pushed in the deep end. So instead of having a hierarchy, and there's no step by step, they're straight in at the top. So you go to a therapist and you say, I've got a phobia of spiders. Boom, there's a spider. And you can't really do much about it apart from panic, and then it disappears and you're totally fine. So they also, well, it depends on what it is. They'll do a little bit of image work, but mainly they just have contact with their most feared scenario. So there's one, I think the video shows someone who is scared of pools because they almost drowned when they were a child. So I think what they've done is just put them into a pool. And over time, it gradually decreases their anxiety level. Controversial technique, confronting the fear of heights, snakes and spiders. Just shove them in a box and they'll be fine. So, appropriateness and effectiveness. So there are two therapies. Systematic desensitization, slowly, gradually working up a hierarchy, and flooding, you're just being flooded with that phobia to the extreme so that, anxiety peaks and then declines. The idea of appropriateness and effectiveness, we have to look, when we look at research or any clinical trials into these two therapies, is how appropriate is that therapy in certain situations, and how effective are they at producing the results. So with anything, with drug trials, whatever, we need to look at these two things. Is it appropriate and is it effective? I've got a couple of bits of research for you to have a think about in terms of those two things. So remember we looked, this is a totally different one actually, sorry. So Jones, using SD to erase little Peter's phobia of white fluffy animals. So would you believe it? After little Albert, someone's decided to come along and do it again with someone called Peter. So little Peter now has a phobia of white fluffy animals. And they used systematic desensitization to try and counter condition Peter. So the rabbit was presented to the patient at closer distances each time. His anxiety levels subsided and Peter was rewarded with food to develop a positive association. So they're using classical conditioning to the reverse. So you do it with a dog. They don't wee on the carpet or they wee outside, you give them a treat. And it's kind of the same with phobias. So this child is being positively reinforced when he gets close to the rabbit. And it is a really good technique to use with children and with small animals. And over time, he showed affection towards the rabbit, and it generalised to other white fluffy objects. So we've got a little bit of positive research for systematic desensitization. It's effective, it's producing good results. I'd argue it's appropriate because you're not really putting them to the max of the extremes. You're rewarding positive behaviour. It is quite mechanistic, but I think it's okay. Whereas, would you believe this? 1960, a girl had a phobia of being in cars. So they used flooding where they just shoved her in a car, drove her around for 4 hours straight until her hysteria stopped. Now, obviously it's producing results. Over time, she was fine, anxiety declined. Is it appropriate? I don't necessarily think so. So you have to be quite careful with some of this research. So what I've attached is an evaluation sheet looking at the two therapies that you can fill in, or you can use the textbook, or you can use notes from this, entirely up to you. So let's have a look at some of the effectiveness for, there's quite a lot of AO3 because we need to look at two. So a kind of question you could be asked is something like, describe and evaluate one or more behavioural treatments for phobias, and you will need to talk about 2. When it comes to AO3 though, because remember AO1 is only 6 marks, so a good bulky paragraph explaining what SD and flooding are, you probably want to go for 2 AO3 paragraphs for SD and 2 for flooding, I'd say, to really make sure that you've got enough in there to show the 2. So because of the anxiety hierarchy, it is effective. Now, when we look at treatment for specific phobias, so things like spiders, Gilroy looked at 42 patients who had been treated for a spider phobia in 3 45-minute sessions. So only 3 sessions. They were given the spider questionnaire and had to assess their response to a spider after each of the sessions. Had a control group as well that only had the relaxations. They were only really taught sort of meditative techniques, didn't have any exposure to the spider. And at 3 months and 33 months after the treatment, the group who had SD were less fearful than the relaxation group. So why is that a positive? Because it's showing that it has long-lasting effects. So over 3 months, but also over 33 months, we have them feeling less stressed in those situations and producing a less physiological response. Okay, so that's a pro. It's also suitable for a wide variety of people. So flooding and cognitive therapies aren't well suited to a lot of people. So people who have got learning difficulties or a neurological disorder, that makes it quite hard for them to engage or to understand what's going on during flooding, for example, because they'll just get panicked and fearful and won't have a clue why it's happening. Whereas for using SD, it's more appropriate because it's slower. It takes a lot of practice, a lot of imagining scenarios, building up to the end goal. They're not just shoved straight in. So it's good. It shows population validity, which means that we can extend it to a wide variety of people and is the most appropriate form of treatment. Last one for SD then. It's acceptable to patients. So they prefer it as a therapy. If they're given a choice, they're going to prefer this because it's less traumatic than flooding. So you can see that's already one of the limitations of flooding, is that ethically, is that right to shove a spider in their face? It's horrible and I shouldn't laugh, I do. There's a YouTube clip from, I think it might be Jerry Springer. Is it Jerry Springer? And there's a woman on there, apparently, I mean, you never know how reliable Jerry Springer is, that has a phobia of peaches. And the audience just throw peaches at her as a way of getting rid of her phobia. Oh, God, it cracks me up every time. I mean, is that real? I don't know, but have a look, watch it. It's quite... It shouldn't be amusing, but it's a little bit amusing. So when they're given a choice, they prefer this because there's not a lot of trauma and because some of it are quite pleasant. So the learning of new relaxation procedures, it means that people are less likely to drop out. So we call that attrition. When people decide they don't want to be part of a study, they drop out. And there's less of that. We have low attrition rates. People are staying in it for longer, completing the treatment, which is good in 2 ways, because it means that they'll be helped in the long term. It will give them some positive techniques that they can use in the future, and also saves them money. So it's quite a cost-effective treatment. On to flooding then. So flooding is also cost-effective because when you're comparing things like CBT, so cognitive behavioural therapy, with flooding is so quick and effective because it's really quick and they see results pretty much instantly after a couple of, 1-2 sessions. And people are free of symptoms sooner and it's cheaper. They haven't got to spend a lot of time developing this hierarchy, imagining all these scenarios. It's straight in there, done, move on. But for a variety of phobias, it's less effective. So for our complex phobias like social phobias or agoraphobia, there's a lot of cognitive aspects, irrational thought processes that aren't really developed or aren't really tackled in flooding. So actually they probably benefit from either a combination of CBT and flooding, or just CBT, to really get down to the root of why they struggle to talk in public, for example, or engage in conversation with individuals. So it makes it less externally valid as a therapy because it doesn't treat, it doesn't look at absolutely every phobia. And then flooding is also, like we said, traumatic. So the most serious problem is people drop out. It's a waste of time, it's a waste of money, because it is such a horrendous experience. They don't see it through the end. There's high attrition rates, and it's cost effective because for some people it works instantly, but for others it can be, depending on what the phobia is, it can be quite, ethically challenging. And that is treatments. So the key thing for this section is, if you're asked a question on it, to use one to talk about the other. So think about now which treatment is the most effective and why, and maybe do a little plan for that essay. Describe and evaluate behavioural treatments of phobias. Then my sort of ending paragraph here would be that, I don't really urge you to write conclusions, because for psychology, I don't think you really get the marks for having a conclusion and an introduction. Some people like it because it gives them a bit of a flow into the writing. But for me, when I look at top band answers, there aren't introductions or conclusions, they're straight in, just because the time limit is so short on 16 markers. Whereas for sociology, you're encouraged to do that because they're longer answers. For this, not so much, but I would try, if you have time, so 20-25 minutes for 16 markers, to finish with some kind of evaluative paragraph. And we'll look at this a little bit more in year 13, but if you're ever asked a question on a biological explanation or a psychological explanation, my finishing paragraph would always be to use the other to say why one isn't as good as that. So here I would say what both these treatments don't look at are cognitive aspects, and maybe CBT could be a better way of looking at it. So it's trying to have that evaluative kind of conclusion, but still it's being clever so that it's still AO3 and not just, I think it should be CBT, because that's AO1. So something to have a think about. Feel free to do a plan and send it to me if you want to, but that is phobias done.